Vă invit pe doamna doctor Danae, de la Stambouli de la București, care ne va prezenta posibilitățile din punct de vedere al unui laborator de genetică ale diagnosticului prenatal. Thank you.
Thank you very much, and it's always a pleasure to come back to this beautiful city of Timișoara. So in this presentation, we'll try to present some general information and practical issues regarding chromosomal detecting of chromosomal anomalies. Okay, it is well known that 2 to 5% of live births have at least one congenital anomaly at birth, and 1/3 of these congenital malformations are of genetic causes. The incidence of genetic abnormalities among unselected group of newborns is 0.9%, among stillbirth 10%, and the overall frequency in malformed fetuses is about 10 to 15%. So therefore it's justifiable to perform chromosomal analysis to all stillbirths, neonatal deaths with or without dysmorphic phenotypes, and all fetuses with malformation, especially when more than one anomaly is present. Since 1956, when Tijot and Revani described the correct number of human chromosomes, the number is 46, there is a scientific effort to define the association between chromosomal abnormalities, genetic diseases, and congenital malformation. And that's why, over the years, different diagnostic techniques were developed to improve the expansion of the resolution of chromosomes, or whole genome, to empower the detection of small structural chromosomal imbalances, sub-microscopic genomic imbalances, to increase the technical sensitivity of the methods, to assist the description of chromosomal abnormalities with precision and accuracy, and to allow, by this way, the identification of an increased number of genetic symptoms. In this presentation, we will focus on prenatal diagnosis of chromosomal anomalies, and two very important issues here. The trisomies 15, 18, and 21 are, as we all know, are the most common chromosomal abnormalities found in abnormal fetuses. Also, the turnaround time of the results, it is an important issue for the pregnant woman. Therefore, in the early 1990s, rapid targeted techniques for the detection of trisomy 15, 18, 21, and X-linked haploid were developed apart from the paradigm. So today, in the laboratory, for diagnostic purposes of chromosomal abnormalities, we have two categories of methods: the targeted methods and the whole genome. We have two types. I mean, we have more, but these are the most used: FISH and the qFPCR, for targeted rapid methods, and for whole genome, the conventional karyotype and the molecular karyotype, or RxGH. I will not go into detail, technical details, only some information. How do we evaluate quickly? FISH, fluorescence sensitization, is a local-specific method, and by which you can monitor any region of interest on chromosome. So it is accomplished by leveling small DNA strands using fluorescent dye sensitization of the probes directly on the sample slide spread. Then microscopic analysis, we evaluate by microscope the number of signals. And as you see here, red is trisomy 21. Here we have 1, 2, 3, we count signals, so it is trisomy 21. Here is, we have 2, it's a normal, and here is an abnormal with trisomy 15. FISH is widely used for detection of microdeletion syndromes, but also in prenatal diagnosis for screening of common anomalies. qPCR. qPCR is the other targeted method. It is a quantitative method that analyzes the fragment size of polymorphic small tandem DNA units that are located on chromosomes. These TSRs, STRs, are chromosome specific and vary in length between subjects. So the samples are analyzed using an automatic sequencer, and the special software is processing the data. So normal subjects here. Normal subjects are expected to have 2 peaks here and trisomic either 2:1 in a ratio 2:1 or 1:2. So qPCR is widely used in forensic, but in prenatal diagnosis also for screening of common anomalies. qPCR versus FISH for prenatal common. So they're both methods. They have high specificity, sensitivity, reliability, and accuracy. They're being performed on uncultured cells or tissue. We get from both fast results within 24 to 48 hours. But qPCR uses DNA, so we need only a few cells. So 2 ml of a mercury, for example, is more than enough. Whereas FISH, we need many cells fixed on a slide. qPCR is automated, so we can run many samples at the same time, whereas FISH is a manual method and the evaluations performed by karyotype, by the microscope. And also the big advantage, and this is very important for CBS, qPCR can detect maternal contamination, whereas FISH cannot in case of female fetuses. So qPCR is the method of choice for aneuploidy detection. So from our experience on rapid tests, we have chosen to use as rapid test qPCR because of the reasons I mentioned before, but also for twin pregnancies, it establishes the chorionicity. So this is an extra class. Plus it is of lower cost. So our experience of qPCR results from 2008 to 2014. We have analyzed 3,884 American fluid samples, and we have detected 132 aneuploidies, so 3.4%. Second semester screening. In the first semester, 532 CBS samples, 86 with aneuploidies detected, 16%. So this slide shows the high performance of screening during first semester. Most common, of course, trisomy 21, followed by trisomy 18, 13, aneuploidy, and triploidy. So from our cases, all 210 trisomies, 21, 15, 15, and triploidies detected by qPCR were confirmed by karyotype. 3 mosaic cases of sex chromosomes were missed. So we have no false positive result at all. So it's a diagnostic method. And here comes the question. In the case of abnormal qPCR, because if we have normal qPCR, for sure we have to continue the investigation by karyotype. But in the case of abnormal qPCR, do we need to continue the investigation by karyotype? The answer is no for the diagnosis of abnormality. It's finished. It strikes me when we have 2 peaks, 3 peaks, we can put the diagnosis. For example, it strikes me 21 finished. But we need to establish the recurrence risk for this data. And that's one. These are 3 real cases from our laboratory. All these 3 cases, they have 3 copies of chromosome 21. here it's in the first karyotype, okay, here we have 3 free chromosome 21. Of course, this is the most common form. Here, this extra chromosome 21 are 2 normal and 1 translocated chromosome 13. And here we have 2 21 to 1 on top of the other. So, in this case, we don't need to continue with any investigation. The risk for recurrence is low. The recurrence risk. Here, in this case and in this case, we have to do parents, and if one of the parents are carrier of this rearrangement, then this is a high risk and this is 100% risk. So, if a parent has this rearrangement, you can never have a normal child. So, since the development of banding techniques, 1956, the karyotype has been the gold standard method of chromosome analysis. Karyotype is the whole genome technique. It is formed by pairing of the homolog chromosomes, identifies all numerical changes of chromosomes, detects structural anomalies up to 5 megabase resolution, detects balanced chromosomal rearrangements, translocations, inversions, but most important, by karyotype, we can study the architecture of genome. So here we have some examples. We can see translocation, which is a normal balanced translocation, a balanced inversion, abnormal deletion, abnormal duplication, etc. So karyotype can be obtained by any divided tissue. In genetic diagnosis, we can obtain karyotypes from CVS, American fluid, American cord blood, etc. But before analysis, we need to culture the cells, so it's a time-consuming technique. It requires well-trained specialists to evaluate the results. Are very difficult, and the turnaround time of the result is between 10 to 15 days. From our experience, karyotype results, again from 2008 to 2014, the same amniotic fluids, 3,800 and 532. We have detected 170 abnormal karyotypes, 38 cases more, and here 94 abnormal karyotypes, 8 cases more. So we had the detection rate increased by karyotype by 1%, and here also for both first trimester and second trimester. So karyotype identified 46 more cases with chromosomal abnormality than PCR. So we have an increased detection rate in 1%, but still remain cases with normal results and multiple malformation on autism. Recent studies on large number of samples from different centers on the application of new microarray based in 2011 and 2012 versus karyotyping for prenatal diagnosis revealed an increased rate of clinical relevant genomic imbalances in malformed fetuses with normal karyotype in 6%, and with advanced maternal age in 1.7%. So since 2015, we implemented this technique for prenatal diagnosis. This technique began in the 90s at Stanford University and improved by sequencing of whole genome projects. It's called comparative genomic hybridization. It was firstly developed to survey extra or missing genetic material across the whole genome with higher resolution than the one of karyotype with 5%. The technique involves a comparison of patient DNA with reference DNA on an RNA platform. The evaluation of genomic imbalances is expressed by the copy number variance, gain or loss between patient and reference DNA. CNVs, which are called CNVs, are characterized as non-pathogenic when they're common among normal populations, pathogenic when they're found in well-defined clinically significant region, and of unknown significance, whose everybody knows about that, when no clinical information is known, and this is really a very the header for the evaluation and the lab. Okay, I'm sure that everybody here has heard the array platform. So, what is an array platform? Is it a machine? Is it big? Is it small? What is it? No, array platform is a glass slide which contains on its surface thousands of pieces of synthetic DNA clones from the genome. So the resolution is determined by the size, the number of the clones, and the genomic coverage. We can design our own array platform depending on what we want. So we have many platforms, array platforms, but the most common are of three types that also they're available in commercial. The back array with a resolution higher than 1 megabase, the oligo array, the resolution is 60 to 100 kilobase, and the SNP array, the resolution is up to 20 kilobase. And you have to put this in your mind. As the resolution increases, the incidence of variant of the boost also increases of unsignificant, unknown significance. Sorry. So, very quickly, how is being performed? We have the reference DNA, we extract that reference and the patient DNA. We label both of them with different fluorophores. Then we mix equal amount of DNA. Then we hybridize it in the platform. Then this we scan it on a scanner where it normalizes the signals. Then a special software does do the data analysis, and this is what we get. This is the picture of a molecular paradigm, a line. So, when the ratio, the ratio in hybridization factor intensities of patient and RNA DNA sequence is normal, then the karyotype looks like this, a straight line. It's normal. Under this karyotype, the molecular karyotype, we have a table with all kinds of information that helps us in the evaluation of the imbalances regarding diseases, regarding genes, databases with publications. So this is the way, this is the Bible for evaluating the molecular karyotype. Here it is an abnormal ratio. Here, okay, you see a molecular karyotype, and you see here an imbalance. This is it's outside from the normal range. It is a shift on the left. When we press this, we get this picture. And this picture shows us exactly which chromosome, which band, what dimension, what imbalance. Loss, chromosome anything, the band, the from here to here, and dimension 14 megabase. Here, sorry, this is another abnormal, but now this is the shift is on the right. Again, we press, we have the chromosome, and the type of imbalance here is gain on chromosome 15, band, and dimension. So, RACGH we implemented, as we said, in the laboratory in 2015. We have used the back array platform. Okay, I'm getting into the end, Dr. Rishan. Okay, and and for each abnormal, we validate the result with either karyotype, fusion, or MLP. And here is our result. Karyotype versus RACGH. 139 cases were referred to us. On all these cases, we begin with PCR because we want to exclude the trisomies. There is no need for the patient to pay and for us to do this work for a trisomy or 15 or whatever. So, 4 were excluded because we had abnormal qPCR. 16 cases out of the 135 cases, we found the structure abnormal. I'm sorry, I'm very bad at this. So, which is 8%. So 16 cases is 12%. On 11 cases, 8% of the 12%, okay, we found abnormal karyotype and abnormal average. We had both. I mean, we could detect the abnormality with karyotype and with average. But in 5 cases, we had normal karyotype and abnormal average. So 4%. 4% increase in detection. So, conclusions, RACGH is a powerful method for whole genome analysis. It's a rapid method. Samples could be used without tissue culture. Detects and analyzes only genomic imbalances below the level of banded karyotype and identifies with high precision breaking points, any extra chromosome material of an origin. It is equally efficient in identifying all aneuploidies, identifies additional clinically significant cytogenetic information as compared with karyotyping, and helps in predictive outcome for clinical practice. So, for all this, it is considered today the first tier in prenatal diagnosis, especially in cases with multiple malformations. Limitations of the method, because no method is perfect. We cannot detect balanced chromosomal rearrangement. We cannot detect triploidy, and of course, single gene mutations. Take-home messages: all methods have their own sensitivity and accuracy for what they have been designed. New techniques as RACGH are powerful methods used in prenatal diagnosis, but referral reason is an important issue in choosing the appropriate methods of analysis. Multidisciplinary teams, the key of better outcomes. Thank you.
Cred că a fost o prezentare destul de acoperitoare asupra posibilităților unui laborator de genetică, cu indicații foarte clare. Întrebări?
No questions. I just wanted to commend you on the excellent presentation. And I was thinking that it would be interesting for us to consider the phenomenon that the number of abnormal of abnormal samples, the number of real positives actually was significantly higher in the CBS population than in the abnormal
This is
population.
what I said.
Thank you, excellent, thank you.
Yes, yes. And this is thanks to you that you're all effort.